We are very privileged to have you all here. We thank each and every one of you for your valuable time and being with us. We are starting with the sessions. Our first session for today is nursing session for Ecmo. I welcome Dr. Monalisa Mishra, Dr. Rajiv Gupta, Dr. Asina Jilopa, and Dr. Saurabh Taneja to please come forward and take the seats.
With the due permission of organizers, I will start with the first speaker, Dr. Tomusha Harishchandra. He is a consultant cardiothoracic surgeon in Gare, Sri Lanka. She is an adult cardiothoracic surgeon with a special interest in adult, pediatric, and neonatal ECMO. She has 13 scientific papers published in journals and 40 presentations published in abstract form. Her MPhil was on blood coagulation changes in hypothermia and neonatal ECMO. She authored several papers on the use of ECMO in severe pulmonary hemorrhage in leptospirosis. In special achievements, he has pioneered the establishment of Ecmo in Sri Lanka and the National Ecmo Center. He is the founder president of GALE Extracorporeal Life Support Organization (GELSA). He is presented with the Sri Lanka Medical Association Audition 2021. Because breath becomes air, a personal odyssey of Ecmo in Sri Lanka. Ma'am is going to speak on how can I make Ecmo initiation a smooth one. Over to you, Dr. Orisha.
Thank you, Chairperson, for the kind words. And I would like to thank the organizers of this work also 2023 as well as the Ethnic Society of India for this kind of opportunity, the wonderful opportunity to come and speak to you and to come back to India again after a break to a country that is very close to the heart of Sri Lankans. For those who have not visited Sri Lanka, Goa is in the south of our country, uh, much further down south than Colombo, and it's a beautiful coastal town. And this is where I live and work, and this is my start. My early experience in ECMO started in Glenfield Hospital in Leicester, which was which practiced high quality ECMO, and it was really textbook ECMO, and I was privileged to actually work there. Now, when I came to work in Boeing and started doing ECMO around 2017, it was not always smooth, to put it mildly. And ironically, I will be talking to you more about what I have learned in Goa than at Glenfield, because what I have seen in Glenfield is available to you in any textbook. So what I will be talking to you today would be what I feel may be important, especially in a low resource setting, and how to make it more smooth. Now, having thought about it, I felt that the key to all of this, to make ECMO initiation a smooth one, would be preparation. And this we found in many ways, and I will tell you some of the disasters we have also had. And these are the 6 areas I felt was important to prepare uh, for ECMO. About referrals, when we first started, the main problems we had were poor communication when we came to accepting referrals. There was trouble filling long forms, there was problems in handing over. There were times when I had already stopped to look around to see have you consented, and nobody had consented. Nobody, I thought they had done, they thought I had done, and then, especially during the COVID time, we had a lot of problems with people asking VIP patients wanting their so and so, please can you do an ECMO? And it was like totally not suitable. So, if you get this wrong, ECMO initiation is not going to be smooth. And there are standard indications and contraindications and very good forms. But what we did was we tailored our referral form to one page because it was so difficult to get the referring physicians to fill any long form. And we assess patients individually, and we need to decide who, when, where, when, and what kind of ECMO is needed. Now, these are textbook indications and contraindications. I don't need to go through them for this audience. But this is the ECMO referral form we did for adults. One page, we have a somewhat similar one with few differences for the neonatal ones. We get the referring physicians to fill this up and send us the x-rays and the blood gases. And this is sent through WhatsApp to a group of 7 people, and we can make a team decision very fast. Um, and and then we decide who will need ECMO. Now, about the where to cannulate, where it is done, in my setup, we take the ECMO to the patient because we do not have a facility for just ECMO. So what you see here would be, okay, we have a neonatal intensive care unit, the pediatric intensive care unit, the adult intensive care unit, and um, so it has it is important that the ICU is familiar with the procedure. Now, we had a lot of problems when we first started, and prior thought is needed, and the discussion with the people is very important. This may seem obvious, but when it comes to little things, it just makes it very difficult if you are not on the same page. Now, the COVID situation, this shows my first COVID patient I had to do. This is a very clear way of how not to do ECMO because we had COVID for a while. A few months, we knew it was going to hit us, but nothing was done till a doctor got it. Right at this stage, none of my staff, this me, trying, and I had to cut down. Grossly obese doctor, and his dad was a doctor, and almost overnight they fixed this this place. We were not familiar with the PPE very much, and none of us were vaccinated. And this is precisely how not to do it more. Where you're going to do it, you need to give some thought ahead and plan. And if not, it becomes extremely difficult. Now, sometimes we get special requests like when it has to be done in theatre. So again, the discussion is important. Otherwise, it's going to be a very rough ride. This is a thoracic surgeon who brought his patient from the chest hospital because he was worried he will crash during taking this off. So we were ready with the simplest way with CVP lines, with balloon pumps and a normal oxygenator, ready to go on if needed only, but we did not need. Similarly, there was an instance when I was required a foreign body for thoracotomy because the ENT surgeons could not take it out. But I thought we should get the ENT surgeons in and ask them to try with our machines on standby. They still couldn't do it because every time the foreign body was trying to be removed, patient crashed. So this is a situation we had planned this nicely with anesthetists, ENT people. We put the patient on, allowing the ENT surgeons 20 minutes, just 20 minutes to take it out. It was a cardiac oxygenator because we have to save money, and this was done, and the kid was fine. Patient was recalibrated on table. So it's important to plan because sometimes it's not unusual things we get. Now, about the patient's pathophysiology, we have a very small margin of error to do it, but and patients are obviously sick, that's why they need ECMO. But if the patient is optimized as much as possible in the given time, and if you don't create complications in the process, that will go a long way for a smooth initiation. And of course, this decision about what type of ECMO to be done needs to be decided. You need cardiac support. So that's post cardiotomy ECMO being done, not very pretty, but or is it going to be peripheral? You need add-ons like cytosorb and CRRT. All this is important to know ahead. And it's easy for the perfusionist to set up the circuit accordingly. Equipment, it's important that they are all in prime position because we've had several disasters, two H1N1 patients on ECMO. We had very severe crisis during this particular time, or no power coming, the power coming on, off. And what we didn't realize was one had a problem with the battery, and the generator didn't come on in time. We had about 3 minutes with obvious disaster situation. So it was very important that we should have checked the batteries. These are not things we really think about under normal circumstances. This is a UPS that actually was plugged in too long and it burned a few weeks ago. CRRT, we used to have a lot of problems when we didn't have the proper CRRT or it was on another patient, so we now have our own CRRT machine. But you need to be, have to have your equipment checked and know what you've got. Consumables again for institutions who have a lot unlimited supply and somebody else does all the buying and purchasing. Everything is smooth. I don't think you'll have to even think about it. But in a resource poor setting, it is so important that you know what you have. Because I have faced situations when they have not had, especially the proper cannula sizes, very little you can do, but other than kind of decide, oh, do we put two venous cannulae in to get the same drainage? I have had instances when even the line wasn't long enough, right? So trying to scramble around trying to get the proper bits and pieces is no good, right? So these are things which make a very simple procedure remarkably difficult. If you don't have the stuff that you need to do and you don't know what it is. If you know what you have, then you can at least run around getting it before you struggle. And about the staff, this is probably our best resource we have. Now what we do is we have delegated responsibilities. So like not like how we started off when each person thinks the other person has done it. We try to periodically train, and it is one of those things about interpersonal relationships. If they are good, life becomes so much easy. And I cannot stress this enough, especially in crisis situations, because if you are good with each other, I mean, you can work out something. If not, it becomes very, very difficult. You need to have data and regular meetings, otherwise, you do not know what made the initiation not smooth. So you have to learn from mistakes. Now, the groups I just want to briefly touch on, our coordinator, who is in the audience actually today, she does a huge amount of work because she's the first contact. She will guide physicians even how to fill the form because invariably, otherwise they used to call me and ask, what's the Murray score? And now she sorts all this out for me, and that is fantastic. And she coordinates the decision in our team because sometimes if we haven't really looked at the phone in time, she will call and tell, did you check? That's a referral. Patients consenting, talking to the relations, and coordinating transfers. All this has now been streamlined. The perfusion team have to be really on the ball with this, and we have a standard method to drive the circuit. They are good with accommodating cytosorb CRRT into it, and they actually oversee most of the equipment and consumables. Because don't have our own intensive care facility, it has been very important for us to coordinate with the ICUs of the various ICUs in this very large hospital I work in. And it took time, but what really helped us was to give them all a checklist. And these are the things which we need done before we actually put our patient in. So now they are good with organizing investigations, optimizing. They even put inside the lines, which is sometimes we just need to exchange the cannulae over the guide wires. And they know what heparin doses to give about the sedation which we need, and having blood inside the ICU when the patient is crashing, yes, that's another thing, having been on the ball with all the electrolyte imbalances. So these are things which will really help you to have a smooth initiation. A surgical team, again, especially when it comes to neonatal cannulation, it's so important that you have all the fine instruments, fine sutures with you. And what we have done again is to have a list of items which is there in the cardiothoracic theatre. So the nurse sets up the trolley the moment the sex goes in. Assistant doctors are very good in making everything ready for the surgeon to cannulate. In my institution, still it's the surgeon who cannulates. Um, Hopefully, the rest are going to take this up pretty soon. all the team members need to be aware of what is happening. I remember very, very well once I had canal fully dilated, my assisting nurse managed to pull out the guide wire. It is remarkably difficult to get in at that stage. So everybody who is having their hands in on this have to know what is happening. And in a resource poor setting where we don't have access to simulation and all the expensive conferences for all the staff members, on the job training and bedside teaching is very important. However, you have to balance patient safety requirements with the training requirement. You just need to make your decisions because your doctors always want to do it, right? And you have to allow them to do it, but you need to have a feel of when to do it. Otherwise, it can be very difficult to make it right afterwards. So finally, if you have a nice institution of your own, it would make life very easy. We have only just started building our own ICU for the National Ecmo Center, and these are some of our patients who turned up: meconium aspiration, PPHN, bronchial asthma, chlorine inhalation, COVID pneumonia. So we have laid the foundation and we built part of it until the economic crisis hit us very badly. So we are now still, we haven't given up, and hopefully we will raise enough funds to continue and complete it. So in summary, what I have tried to tell you actually is very simple, is that preparation is the key. If you want smooth ECMO initiation, you have to concentrate on these areas. I would like to acknowledge especially Dr. Richard Furman from Redfield Hospital, who taught me everything I know about ECMO, and I'm so grateful to him. And this is our first training session in my institution, cardiothoracic unit. And he continues to support us in all that we do. And of course, I thank the patients and the parents for giving me permission to put their pictures in. And I hope all of you shall visit Royal someday. Thank you very much.
Anyone?
Yes, we have managed to put up to the first lab, and it's sorry,
Where? Where? Location, ma'am.
oh, it is just adjacent to the cardiothoracic intensive care unit. It's because it's the same people who are doing it. So my own anesthetist is the intensive care physician, so he's also helping with the IC, intensive in my ECMO work. So it is adjacent to the intensive care unit for cardiac patients.
It's in God.
Sorry?
It's the
It's in
same.
Goa. Yes, yes, it's in Goa, my beautiful coastal city which you have to visit.
Any more questions from the audience? Another question from the chairperson.
Ma'am, what is the geographical area you cover for retrievals in ECMO?
The entire country, we have only one center, right? So we have 22 million people, right? And that's the only place that does it. Even from Colombo, they send to Goa.
That's really remarkable.
Thank you.
Ma'am, you told us about the timeline for 7 people to coordinate
Oh,
after filling
yes.
the form. What is the
Yes.
timeline, ma'am?
Sorry, the timeline.
The timeline 7 people coordinate the form and
Yes,
decision.
it's actually remarkably fast because when the coordinator gets it, the 7 people include myself, the coordinator Dr. Kapilani, Dr. Richard Furman in UK, our microbiologist here, she's so enthusiastic with the entire thing, my anesthetist. All of these people will see it immediately, all see it's a group. And immediately we will tell what we think is needed. So a decision is made very fast. Within maybe, how much do you think, Kapilani? About 20, 30 minutes, we can
Wow.
come to a decision.
This is amazing, ma'am. And how did you prepare for COVID after the first case?
Oh, yes, that was a disaster. So then it was shifted to a medical intensive care unit. This was like a cupboard kind of thing that it just sprung up from someplace. And we were quite horrified because it's very difficult. Then the moment we started doing the ECMO, they also started getting a lot of COVID patients. So the hospital had to take out all their medical patients and then make the medical ICU the COVID ICU, right? And then it was somewhat better, right? So until during the entire crisis, it was just COVID. Medical ICU was just COVID.
Thank you once again, ma'am. It was a pleasure listening to you.
Right, thank you.
In critical care in Army Hospital, New Delhi. He has done his graduation from Patna Medical College and Hospital. He has multiple international and national publications. His area of interest is Ecmo, CRRT, and mechanical ventilation. And in other achievements, he has been the president of ISA Lucknow chapter. He has been the ex-secretary of ISA in Lucknow. He has been the ex-secretary of ISA Lucknow chapter, and he has also been awarded the Award of Excellence at Criticare 2018, and he has also been the ex-chairman of Dr. Arnold Hospital. I welcome you, Dr. Arnold.
Thank you, madam, for such a kind introduction. First of all, I'd like to thank the organizers for giving me this opportunity, as well as I wish them a successful conference. With due permission from the chair, I would like to discuss about the monitoring, how to monitor the patient on ECMO, because careful monitoring is an essential part for successful running of ECMO. Before I start, this is the picture where I came across ECMO for the first time in my medical career. This is the Cambridge hospital where ECMO was being. This Papworth hospital runs a training course at Cambridge, and this was the first occasion where I got to know about the ECMO. And this is the team of trainers. And this is the pic of first of my patient, who was a 21-year-old guy suffering from acute pancreatitis with ARDS, with AKI and sepsis. And this patient has had cardiac arrest as well because of severe hypoxia. Later he was put on ECMO with this team. This is the pic of the day when he was extubated off ventilator. This is the pic when he was first discharged. This is first pic when he later came to visit me, and this is the picture where he is getting married. So now coming to the topic, if we see when a patient is on ECMO, there is actually a two circulation which is existing. There is one native circulation and one ECMO circulation. So monitoring should include both the parameters, like patient parameter, we should look after the clinical parameters, laboratory parameters, as well as we should do the circuit monitoring. So in my lecture, I shall be discussing about the what are the different monitorings related to patient, related to nursing, as well as the circuit. As far as clinical examination is concerned, we must look at the peripheral circulation. Like we should hourly examine the different limbs of the patient, where there is any color change or capillary refill, or if there is any edema. Especially so when the patient is on VA ECMO, because we all know that there is perfusion issue in the limb where we are doing the cannulation. So we should be careful. Along with peripheral pulsation, we should also look after the heart rate of the patient. Usually, these patients, when they are being put on ECMO, have tachycardia. But this tachycardia settles within 2 to 4 hours. But if tachycardia is persisting beyond 6 or 12 hours, then we should be worried. Why is the tachycardia still persisting? That may be because of sepsis, maybe because of the patient pain is having, and probably our analgesic or sedation is not adequate enough. So we should think about that. It can also be because of inadequate blood flow. Suppose our ECMO flow is not adequate and it is not really meeting the tissue oxygen demand. That can also be one of the reasons of tachycardia. So probably we need to increase our flow. It can be because of the poor LV function of the patient, especially when we are putting for cardiac elevation. Blood pressure monitoring is also essential. Usually we are doing invasive arterial monitoring in these patients, and the cannulation site can be either left radial or right radial. But if we are putting the patient on VA ECMO, it is preferable to do right left arterial cannulation, because then you can monitor the ECMO flow whether it is adequate enough or not. But if the patient is on VV ECMO, you can do left or right anyway. Here we have to remember that the pulsatile flow you will get in invasive arterial monitoring if the patient is on VA ECMO, because in VA ECMO flow is non-pulsatile. But if the patient is on VV ECMO, we will get pulsatile flow, and target map should be more than 70. We should also monitor the pulse oximetry of these patients, and especially in all the legs, because if sometimes what happens that patient is on VA ECMO and we are having a pulse probe on the left hand and it is showing 98, 99%, but probably right hand is not getting well perfused. So we should alternate between left and right hand monitoring of the oxygen saturation. The target oxygen saturation in VV ECMO is more than 85, whereas in VA ECMO it has to be more than 90. In VA ECMO we have to be careful that saturation may not be good enough because there is no pulsatile flow. So saturation flow may not give you the accurate value. Temperature usually these patients maintain very well because these patients are on heater cooler unit, so set temperature is maintained, but still we must must monitor surface as well as core temperature, and we should maintain between 98 to 99 degree Fahrenheit. We should essentially monitor these patients neurologically because we all know that there is no benefit of putting ECMO or running ECMO if the patient's neurological status is not good enough. So we must practice sedation vacation in these patients so that we can assess how the patient is neurologically. And this is especially important in neonatal patients because the risk of intracranial hemorrhage is very high in neonatal patients. So we must do some sedation vacation and do neurological examination, preferably every day. We can also use NIRS for regional monitoring the regional saturation of brain, especially in VA ECMO where there is some risk of that north south syndrome. So we should be worried for that. And if center has facility of NIRS monitoring in VA ECMO, we must do. Now coming to mixed venous saturation. This should also be monitored, especially for knowing the adequacy of ECMO flow, whether whatever you are giving the ECMO flow, whether that is adequate for maintaining the tissue perfusion, for meeting the target of oxygen delivery to the tissues. So this can be done by continuous through the monitor biotrend, or we can intermittently do the venous blood gas monitoring as well. This gives an idea about the adequacy of oxygen delivery and patient's oxygen consumption. In VV ECMO, though, this monitoring may be erroneous because we know that the oxygenated blood is returned back to the venous side. But in VA ECMO, it will be accurate and it should be maintained above 70 in adults, whereas in more than 65 in neonates. And whenever it is going below 65, we should be worried that probably our oxygen delivery to the tissues is not adequate enough. Now coming to other monitoring is the pressure monitoring at different sites of the circuit. And there are three sites where we routinely do the pressure monitoring. One is pre-pump, which is called P1. Another is pre-oxygenator, this is the oxygenator, so this is pre-oxygenator, also P2, and this is post-oxygenator pressure. So this is traditionally called P3, and the difference between P2 and P3 is called delta pressure. So pre-pump pressure is P1 is usually minus 20 to minus 50. Up to minus 70 in adult population may be acceptable. The causes of low pressure can be, suppose it is going beyond minus 70, we should be worried that probably our size of drainage cannula is not adequate enough, or there may be kinking or malposition, or there may be thrombus, so we should be watchful. This can also be due to hypovolemia, which is a common cause in ICU setup, and this can also be because of the high ECMO flow rate. So probably we need to go down on the flow. Another pressure is the pre-oxygenator pressure or P2. It is always on positive side. This will depend on different type of oxygenator, what surface area it has. Usually silicon membrane oxygenator has a higher pressure in comparison to hollow fibers. If flow rate is high, then also pressure will be high. If the size of the return cannula is small, that can also lead to increased pressure. If the SVR is high, that can also cause high P2 pressure. In VA, it is more in comparison to VV more. So we should keep an eye on the pre-oxidative pressure. Another pressure which we monitor is the P3 or post-oxidative pressure. Now this will depend also on the type of oxygenator as well as surface area, also on the blood flow rate as well as on the resistance which is imparted by cannula size or kinking or SVR, and this is also more in VA in comparison to VB, and we should keep it always below 300. Another monitoring is of delta pressure, which we said that it is the difference between P2 and P3. This is the difference between pre and post oxidator pressure. Each type of oxidator has its own acceptable delta pressure limit, which you will get on the description of the oxygenator. This, if this pressure is increasing, this is an indicator of clogging of the oxygenator. So we should be worried about that. And we have to remember that the trend of increasing delta pressure is more important rather than the one absolute value. Another important parameter is the RPM value. It should be monitored hourly. Usually a constant RPM should give a constant flow. But if there is increased flow with same RPM, this can be because of increase in preload, or there may be decreased post-membrane resistance like improved cannula position or vasodilatation. There may be decreased flow, you may get decreased flow with same RPM, and this can happen because of the decreased preload like in hypovolemia, or it can happen because of kinking or malposition of the venous cannula. This can also happen when there is increased resistance like vasoconstriction or kinking or patient has hypertension. Another important parameters which we should monitor when the patient is on Ecmo is the flow rate. Usually we have to maintain between 60 to 150 ml per kg per minute. When we are starting the Ecmo, we usually start with the rate of 20 and then gradually increase it by 10 ml per kg per minute every 5 to 10 minutes, when and ultimately we reach to our target flow rate, and this target flow rate should depend on oxygen delivery and SVO2. So suppose we are putting a patient on VV, usually we target a saturation of more than 85. It should be least acceptable to maintain the target. So because we all know that if we are increasing the flow rate, this has its own complication. So we should try to keep it minimum. Another monitoring is of gas flow rate, also called sweet gas flow rate. It should be set in relation to the blood flow rate. Usually we keep it in the ratio of 0.5 to 1 is to 1.5 is to 1. So suppose blood flow rate is 3, so we can keep it around 1.5 to 3 liter per minute. This flow rate is decided by PaCO2 level in ABG. And if it is CO2 is high, we need to increase the sweet gas flow rate. If PaCO2 is low, then probably we need to go down on the sweet gas flow rate. In between, because after some times there is always condensation of water in the gas circuit, so we should do a maneuver cuffing, which is we usually do at 10 liter per minute for 10 seconds, so that whatever moisture is there and clogging the circuit, that sweeps out. Another important monitoring is to monitor the circuit every day. So we should start from arterial to venous in, or we can do from venous to arterial in, but we should do in continuity, and we should check for any clot or any air, or if there is any leak from any of the junction. We can also look for certain fibril strands, which is indicator that probably no clot will happen in the circuit. We should also check all the junctions. We should check the cannula position. How is the dressing? If there is any oozing from there, or there is any kinking, position is okay or not. That should also be confirmed. We should also look at the gas blender, because sometimes what happens that there is a leakage from the connection where gas blender is connected to the wire unit. So we should look at all these places, and we should always check whether our emergency items are ready at all the time. Now here we can see that these are two pipelines, drainage and return pipelines, and both have same color. So we should always be careful for the color in the different part of the circuit, and if they are matching, probably recirculation is happening, and we need to address that. Now ventilatory parameters should also be checked. Rest setting is there or not. If patient is on BD ECMO, like low tidal volume, we have to set. Usually we don't set tidal volume, rather we keep on the pressure targeted modes, and our peak pressure should always be less than 30. We should always measure respiration rate. It should not go beyond 20 to 30. Peak we usually keep around 6 to 10, and we should watch how is the compliance of the patient, because improving compliance will give us an idea that probably the lung pathology is improving. We should keep a low FiO2, and we should also keep an eye on the EtCO2 to maintain the Ecmo sweet gas flow rate. Now, coming to laboratory parameters, we should look at the coagulation, anticoagulation parameters like how is the ACT. Normally, we target between 180 to 220 seconds. And initially, we do hourly, but later on, we can do it 4 hourly as well. If there is elevated ACT, probably we are giving more heparin or patient may be having liver disease. If low ACT is there, we need to increase our heparin dose. This anticoagulation, effective anticoagulation can also be monitored by APTT. Usually we target 1.5 to 2 times of the normal. Antithrombin 3 can should also be monitored if there is increased need of heparin, because we all know that increased need of heparin is mostly because of the lack of antithrombin 3 in the patient. So we should monitor this, and our level should be maintained above 70%. As we all know, we are using heparin, and best monitoring of heparin in the patient is anti-factor A monitoring, which is a functional assessment. Normally, range is between 0.3 to 7.7, and if facility is there, then it can be monitored once daily, and level to be maintained is above zero point 0.3. If your center has TEG or ROTEM, you can monitor coagulation parameters with this also, because we all know that this measures all the phases of coagulation. Other parameters which we should target is for intravascular hemolysis, like what is the level of hemoglobin, if it is deteriorating very fast, or we can monitor for plasma-free hemoglobin, which normally is less than 10. In Ecmo patients, we target is to keep below 30 milligrams. We can also look for hemoglobinuria in urine or bilirubin level in the patients. We should also do ABG monitoring in these patients, usually twice daily, and target PaO2 should be more than 50 to 60, and in post-oxygenated ABG, PaO2 should be more than 150. The cause of low PaO2 may be because of the lung function is deteriorating, or maybe our ECMO flow is not adequate, or sometimes if patient's cardiac output is more than ECMO flow rate. The causes of high PaO2 can be because of lung function is improving, or our ECMO flow rate is probably high, and native cardiac output is low, then also we may get high PaO2. And PaCO2 will depend on the sweet gas flow rate. We should also look for acidosis or alkalosis, and also look for lactate, because we all know that lactate is a marker of tissue perfusion. So if tissue perfusion is not adequate, the level of lactate will increase, and probably in such scenario we will need to increase the ECMO flow rate. Radiological, we should monitor the chest X-ray for seeing the pathology of lung, as well as we can see the cannula position with the help of X-ray. We use ultrasound also in these patients for the time of cannulation for the correct placement, as well as for seeing the tip of the catheter, these cannulas. We can need to do ultrasound abdomen if we have some issue, that probably some ascites or some hemorrhage is there, then we can go for energy abdomen also. Sometimes we send the patient for CT also, because if the patient's ECMO running is more, and we want to see the pathology, whether it is improving or patient has developed honeycombing, so we sometimes send the patient for CT also. So to summarize, the take-home message for monitoring of the patient is thorough monitoring of clinical, machine-related as well as circuit-related may appear cumbersome, but are essential component for successful running of ECMO. And regular monitoring may help us in assessing the adequacy of ECMO support, whether our ECMO support is adequate or not. And we can also forecast if there is any upcoming issues, and it also helps in timely prevention of timely implementing the preventive action. And documentation is very important, because we also just now discussed that it is the trend which is more important rather than absolute value, and that can come with the documentation only. And at the last, I can say about the monitoring that hours and hours of boredom is interspersed by moments of stark terror when we are having the patient on ECMO. Thank you.
Thank you, sir, for that informative presentation. I'm sure it was very helpful. Any questions from the audience? Sir, I have a question. Do you prone in a center or patients on ECMO?
Initially, when we were less experienced, we didn't. But later on, now we prone the patient even on ECMO, especially when lung pathology is not improving. We have that.
So, for the benefit of the students, and I would like you to illustrate what extra precautions we should take and what we should monitor while proning a patient on ECMO.
See, when proning is always difficult, whether patient is on ventilator, then also we need to be careful for decannulation. Central lines are there, arterial lines are there, and there is always risk of detachment of these cannulas. But when patient is on ECMO, we need more persons. We usually need 2 to 3 more persons who will take care only and only for the cannulas so that they are not getting dislodged. But we have not find much difficulty in cloning also. The only thing is that we need to be careful.
Thus, what is your opinion about the fibrinogen level and the D-dimer level monitoring?
Yes, if we have any doubt about the DVT or pulmonary embolism in these patients, because although patient is on heparin, but it may be inadequate, so we can monitor them also, but only when we have any suspicion that patient has, because these patients have less risk in comparison to other ICU population because they are always on heparin.
Actually,
Or
in
Boni
our,
sir can say
actually in
something
our
about it.
center,
Usually we don't do we don't, you have to do the dimer for ruling out DVT or pulmonary embolism and you,
no, it is very important for the circuit clot, any circuit clot. As you mentioned, fibrin stents. When you observe some fibrin stents, you must go for fibrinogen level and D-dimer.
exactly, when we have doubt in mind then we need to do. Oxygenated function is impaired, usually maintained.
Close to the time we can do it. It may not be daily parameter to watch.
Thank you for the lovely presentation, sir.
Thank you.
Now, our next speaker for the morning session is Dr. Nan Kishore. He is pediatric intensivist, Ecmo specialist, and practicing in KIMS Hyderabad. He got his initial training from UK, and he has got the credit to establish Ecmo program in KIMS Hyderabad and first in Telangana state. Welcome, Dr. Nan Kishore. He is going to talk on nursing care in Ecmo.
Much for kind introduction. And at the outset, I would like to thank organizers for giving this opportunity for me to be here at the great event. So, I'm going to talk about nursing care when the patient is on ECMO. A lot more is already covered in the previous two speakers. So, I'll try to skip those things a little bit faster and go to the things which are not being covered. So, let's start with this thing. When does the nursing care start? It starts as soon as you get a referral, not when the patient is on ECMO in ICU. As Tunisha mentioned, there are a lot of issues even before the patient comes to ICU. You need a lot of preparation needs to be done. So it starts as soon as you get the patient. And you need a how sick is the patient demographic details, what kind of support is going to need in addition to ECMO, like if he is he going to need CRRT, do you have enough nursing or team members are there to take care of those things? Or does he need any special isolation facilities? Where is going to keep the patient? And how many people you need to take care of the patient round the clock? And all those things need to be taken into consideration and make sure all your circuit, dilators, everything is there. And one important thing I would say, reserve the blood always the moment you get a call. Or ask the referral unit, reserve a blood, get blood when you get the patient from there. Because that always takes another extra half an hour and that is itself an important time for us. And the consent is another thing which has been overlooked. So take consent even before you touch the patient. So when you go on ECMO, when the patient stabilizes, uh, come down the supports, the ventilation or the inotos, whatever you're trying to give, come down to minimal support as soon as you get the opportunity when the patient gets stabilizes. And always do a bedside echo or ultrasound to confirm the cannula position, then followed by the X-ray to confirm the position. And when the patient is on ECMO, he's like any other critical ill patient as long as you have a little knowledge in how to take care of the circuit side of things. And there is always a debate how many nurses you would need to take care of this patient. In ideal situations, if you have a more number, two nurses or at least one nurse and one perfusionist and for one patient, that would be ideal. That might be luxury for all of us here. So we go with one nurse to take care of both the patient and the circuit. But we get around the problem initially. We ask our perfusionists to stay at the bedside until the nurses get used to the circuit, how to, what are the things they need to look at the circuit and how to troubleshoot, or at least whom to call before do something and call for some help. So we make sure that the perfusionists were there until they got exposed to the enough patients, and then after that it was one to one. So one nurse looking after both the patient and the circuit side of the things. Uh, and then we need to document all the things on PK Dasar mentioned about all the vitals from the patient side and as well as the circuit side. Uh, and it's always better to have checklist kind of thing so that even that single point of care is not missed. This is what we follow at our university, looking at the various looking at the patient demographics and your cannulation sites and sizes and the pump type and what it use and all circuit related parameters is documented here. Your pre and post membrane pressures, your delta pressure, ACT, SCVT, all those things. We document hourly basis. And then the safety kind of checklist goes through every shape. The nurse who is at the bedside and go through all the safety checklists at the bedside, make sure that all the care points have been addressed. And then look at the cannula side. So, is there any bleeding from the cannula, which is the commonest thing can be seen, or is there any inflammation around the cannula side? And make sure there is no undue tension or pulling pressure on the cannulas, and always fix the cannulas along the long axis of the link with a transparent dressing. So this is what I meant. If you have these kind of things, you can fix it, but fix it along the long axis of the link. And this is what we normally do. Fix it along the long axis and put a transparent dressing from entire length. So this helps us even when the patient is moving and flexing the leg, cannula is not moving in and out, it's moving along with the leg. And for the neck cannula, this is what we do. We'll take a loop and fix it on the chest again. So that even when the patient is rolling over to one side, so there is no pulling on the cannula. As Dr. Pickles had mentioned, if you have veno-arterial leg, we need to make sure that a distal profile is maintained. So this is a 2-year-old girl that has veno-arterial ECMO because of myocarditis. This was done percutaneously, JNS cannula by sending a technique. This was an open technique where we put an antegrade flow cannula in the femoral artery, and to maintain the distal coefficient, we put another smaller cannula into the distal artery, which is being connected to the circuit through the Y connector here. So that's a distal perfusion. So that is important to maintain the distal perfusion of the leg. If not, this is what is going to happen. You see the ischemia of the leg, and there are instances it is not taken care, even amputation has been done. So you need to prevent all those things. And one point of important point is whenever you put a cannula here, this is not going to be pulsatile flow. So you're not going to pick up in pulse oximetry, you're not going to feel any pulses here. The only way you can make sure the perfusion is good is by clinically. That means you look at both the legs, see, both the color are okay, both the temperatures are okay. And if you really want to be sure, do a droplet to see the flow. And if you have a facility for near-infrared spectroscopy, then you can look at for the saturations in both the legs. So whenever you put a cannula, make sure that you have some measurement there documented that and make sure that every shift that is not being moved. And usually, in my experience, first 1 week is okay when the patient is on okay. After 1 week, everything becomes loose, even the sutures cut through the skin, and the patient becomes a bit more mobile, and that's when the problems is going to start. So make sure that the cannula is whatever you started it in the same position. And coming the circuit, make sure that all the connections are there, tightly connected, nothing is loose, no leaking, and there's no clots, and make sure that all the circuit is visible to the team. Nothing is hidden underneath the patient thigh or underneath the bed sheet. Uh, and don't break it in circuit unless it's absolutely needed. Any medications, anything heparin, even if it is given, we give it to the patient. But in emergency, you can use the circuit as a vascular access, but don't use the circuit as a vascular access. Because unless you experience with it, there's going to be a problem, and especially if any loose connection pre-pump, you're going to get air going exactly to the circuit and get air embolism. So this is a short video just to show the chattering of the tube. This is the venous side of the drainage circuit. This is the return. This is the one I'm going to shake a little bit, jerky movement. That's the chattering in the circuit. That means patient is hypovolemic. So that's the jerky movement you can see. That is the one. That means patient is hypovolemic or a cannula is the circuit is staying somewhere. And this is the clots which can happen at the connector sites. So monitor for those things and make sure there's no fold and kinks in the circuit. If anything is there, usually when the pressures will drop down, patient gets desaturated. And there's an air embolism. If you see this kind of things, make sure you have two clamps which clamp either side of the embolism and stop the pump and work it your slowly aspirate these air bubbles to the nearest pigtail. But remember that during that time, patient is going to be off ECMO. So be careful that that can be a disaster. So be prepared for those things. And a lot of connectors are there. Make sure all the connectors are well connected. Nothing is loose. Coming to pump, make sure the pump head is fixed properly. If it is fixed, it shouldn't hear any noise. If there is any noise, that means either it's not fixed properly or there's a crack in the pump head. So just be aware of that. And always have a backup plan what if pump fails. I mean, the circuit, mechanical electrical circuit, there's a chance that it's going to fail. So what is your backup? Either you can have a backup like this, have a hand crank at the bedside, not somewhere in the around the patient. It needs to be very close to the pump, where you can actually shift this immediately there. Many times I see this is lying around the patient. It's close to the patient, but it's not ready. This is for the rotor flow, but if you do not have a rotor flow, some other ECMO console, have a backup plan. Always, either it could be hand crank, have another console which is powered and the battery is there for that. And sometimes, if it's a prolonged ECMO or overheating of pump, and you can get hemolysis. There is a clots in the pump head, and this is a patient, pediatric patient, 3-year-old on ECMO for 72 days. After 40 days of into the ECMO, one day in the morning we could see the red hematuria, and this is because of hemoglobinuria. It's not because of the bleeding, because of the heparin. Because of the prolonged run of ECMO, there was a clots in the pump head, and the child was hemolyzing because of that. Once we changed that, that got corrected. So coming to oxygenator, which is the most important thing in the circuit. What we're looking at is the pre and post membrane pressure difference, pressure gradient. So, as Dr. P.K. said, there's a number for what is the normal pressure difference. Document what is the pressure difference when you started ECMO and see what's happening over a period of time. Say if you started ECMO, the pressure difference is 50. Now after 2 weeks down the line, pressure difference is 150. That means there's something happening to the oxygenator. Most likely the clots are happening. So the oxygenator may going to fail probably. So then in those situations, you need to have a backup oxygenator or maybe electrically change the oxygenator. Don't wait for the oxygenator to completely fail and patch change at that time. So showing the clots in oxygenator. If oxygenator is going to fail, the delta pressure is going to increase, patient is going to desaturate, and the blood flow is going to come down. This is just to show that it's a flow and the sweet gas ratio. Usually we maintain 1:1 to begin with, and then depending on your carbon dioxide level, arterial blood gases, then you adjust that. This is a heater unit. This is needed to maintain the normothermia of the patient. mainly so for the pediatric age group, because when so much of blood is coming into the circuit and getting exposed to the room temperature, the high risk of hypothermia is there. So you need to make sure the patient is not getting hypothermic. So for that, you need a heat exchanger which is connected to the oxygenator. For the same reason, patients may not mount fever even though if you have a infection, because you try to control the temperature. So fever is not like you won't be able to see as a marker of infection or sign of infection because they don't get temperature that much. And with neat and tidy, that's how it looks. One of the most another important instrument in armamentarium is a flashlight at the bedside. One need to go from the one end of the circuit to other end of the circuit with the torchlight during every shift, making sure that all the connectors are connected very well and no clots are happening or not propagating. And avoid all invasive procedures if possible. Don't do unnecessary procedures. Well, there are instances we've done even surgeries on Ecmo when it is needed, but do not do unnecessarily because patients are anticoagulated and they're going to bleed. And just to share my own experience, a long time ago in the beginning when we had a 62-year-old with swine flu, ARDS on Ecmo, patient started rectal bleeding after 2 weeks into the illness, and we did everything to find out the source of the bleeding. We couldn't find it. It was a she was pouring out blood like anything, and we needed to give like 2-3 units of blood every day. And it turned out finally, after 2-3 days of investigation, it turned out she was bleeding from the just above the anal orifice. And one of the I gave enema because she was not passing motions, and they gave inadvertently they punctured the small artery there, and she was bleeding from there. So even the procedures like that, make sure that it's done by the senior person taking care of these things. And physiotherapy is like any other ICU patient. And we had a question about can we put the patient on ECMO? I think we should. And there's no contraindication unless patient is hemodynamically unstable or very sick or open chest. That's a different reason. But if the patient is stable on ECMO, he should be able to do it. But make sure that the skin is integrity is preserved because many times these patients are heavily sedated, paralyzed, and you don't want even the slightest movement of the patient. And that goes on for weeks. And then a high risk of pressure sores are there, so make sure that you put a bed, make sure that even when the patient comes to the ICU, you're going to anticipate these things, put a pressure bed for the patient, and then roll the patient regularly, even though you're not prone it. You can change the patient as long as you take care of the cannula size. And they are like anybody else, you can do sedation holidays, provided it's stabilized on it. Initially, a few patients, my experience is some of them ARDS, they have a lot of air hunger when you come down the sedation. So that is not the time to give sedation holidays. But when they get stabilized, then you can do sedation holidays. And nutrition is one of the things overlooked always when the patient is critically ill. There is no contra. ECMO is not a contraindication for nutrition. Patient is hemodynamically stable, start enteral nutrition as soon as possible. Not only for nutrition purpose, it will also help preventing the gut translocation of the bacteria. So a little bit on the physical physiotherapy. Some challenges on ECMO is because the sickest of the sick patients, there's a circuit attached, which is life is dependent on them, and many times we don't have enough staff and we don't know. We're a little scared. I mean, is it necessary to do it or not? Or shall we postpone to next shift and next day in weeks? But there are a lot of studies done to say that is it feasible and is it safe? And all of them said it is feasible and safe. And there are a lot of advantages also there. The patient is awake, they can communicate, a lot of less issues. But you can see actually these patients are extubated. But this is extreme form of this thing. But there is a select group of patients where we can actually extubate them. And some of the patients we can actually do it. Physical therapy also, mainly patients who are waiting for the lung transplant. So physiotherapy is possible and safe, but you need to plan everything meticulously. This is our 3-year-old patient on ARDS on phone position. Pediatric patient may be a little easy because less weight, but even adult patients can be done. And in the COVID, we actually done even 100 kilo patients also being prone. This is another patient kind of midway mycoplasma ARDS the second week into the illness. So we did a tracheostomy and he was air hunger was better by then. He was okay, obeying commands. So we stopped the sedation, did tracheostomy, woke him up, and he was in full ECMO and he was able to communicate. Even the pediatric patients can be extubated, uh, but again, you need to choose your patients correctly. So a little bit about pharmacokinetics. Membrane oxygenator is a lipophilic membrane, so it's going to absorb all the lipophilic medicines. So you need to be a little careful if you're giving those medicines. Be aware of that. Those drug levels may not be maintained in the blood. And again, certain drugs can be absorbed by the circuit, especially fentanyl and midazolam. So those requirements may be high when you're beginning with Ecmo. Infection control, I think, is one of the most important aspects for our settings because when we see the prolonged run of ECMOs, patients die not because of primary illness, they die because of the secondary infections. If you can take care of that, I think at least some of the patients can be saved. Couple of two important aspects from the nursing care is the communication, particularly to our scenario, the too many doctors and too less nurses when the patient is on ECMO. And then every doctor comes and gives an order. And he's a poor nurse who has to face these things and try to balance and not make sure that nobody is upset. And I'm sure that's not an easy job. So I think they need to empower and they need to take charge for the patient and say what is their priority. And their priority is the patient. And I think nurses are the best advocates for the patient because they are there 24/7. We come as the doctors for the snapshot for 5 minutes, walk around, and 10 minutes, walk and walk away. So I think we need to empower the nurses to take the charge and be advocate for the patients. And they're quite helpful bridge between the doctors and the family because doctors only give the bad news and walk away, and nurses have to deal with the families to try to console and do rest of things. So I think I want you to take from this is you need to be empowered and take charge for your own patients. And another thing, training is an issue for us. Not a lot of training opportunities. And the sectors where the many ECMOs are not being done, you don't get that many opportunities to train. So one of the ways is to conferences like this, and ECMO Society has started a regular training program. And in addition to what we do in our own hospital is do regular water labs and simulation based training. And I feel simulation is in a way is changed the way you can train the people, put them in real time scenarios. So that helps us to train the team and team coordination as well. And one last important aspect is always have a emergency plan. What something goes wrong, what to do, and whom to call. What to do? Isolate the patient from the circuit. So you need to have at least two clamps where you clamp the drainage and the return circuit, and patient is isolated from the circuit. And one team has to deal with the patient, maybe go up on ventilation, increase inotropes, or maybe start CPR. And somebody else deals with the circuit as soon as possible, either deal with it and go back on the patient, or the patient is well enough to come off ECMO. And have your members whom to call in emergency. And a big bold letter somewhere pasted close to the bed. So to conclude, always better to have a checklist kind of thing to go through each shift to not even single point of care is not missed. Care of the patient is like any critically ill patient, as long as you take care of the certain aspect of the cannulas and circuit. For that circuit, knowledge is very important, and always have emergency planning. Always call for help. Thank you very much.
Thank you very much, Dr. Nankishore. Session is open for quick questions. And Dr. Nankishore, you very rightly shared information regarding nursing care in ECMO care, for patient in ECMO care. I personally like that your talk about reserve the blood because we often face the problem during the crisis, and these patients need immediate blood requirements, blood products requirement, and most of the time it happens while shifting change.
Yes.
So one sister did order to the blood bank, and other who's taking care of next step don't know about that. Thank you very much.
Yeah, I think everybody is going to say difficulties. Yeah, thank you very much.
It is the end of the first session of the morning.